Welcome to the Knowledge Exchange Education, the biopsychosocial lower limb. The goal of this pre-learning is to introduce you to the various aspects and topics that we cover over the 2-day face-to-face component of the course. If you have done one of our courses before, then you may be familiar with some of these concepts. And if you haven't, we hope this pre-learning provides you with some understanding about our courses. The pre-learning. The pre-learning is made up of 5 parts. After watching this introduction video, we then ask you go ahead and read the case study that follows and answer the associated questions. The case study will be followed then by a video on osteoarthritis and the brain, as presented by Associate Professor Tasha Stanton. Finally, we ask that you answer the associated questions to this video. If you have time, please check out the TED Talk that we post in section 6 of the pre-learning. We will talk a little bit more about this TED Talk and the themes that it talks about on the first day of the course. Before you come to the course, please download the Poll Everywhere app and join Brendan Mowat 878 on login as a participant. More information will be given to you on the day of the course. So what are we going to cover? This course is not an anatomy-focused course. It is a critical thinking course that incorporates a biopsychosocial framework with an emphasis on pain science in the management of common lower limb pathologies. Through doing this course, we hope that you can gain a further understanding around the epidemiology of lower extremity pain, an understanding of the fundamentals of pain science, give everyone an opportunity to discuss, think about how and why we make clinical decisions, understand adaptive frameworks that can be used to assess, manage and rehabilitate lower limb pathologies, and finally, find other ways to simplify complexities associated with the lower limb. In the course, we will cover in detail aspects of the objective and subjective assessment that are critical in gaining positive outcomes with patients. Over the 2-day course, we will cover in detail the assessment form that we use. However, it may be beneficial to review the form now so that you are at least familiar with it, as we do refer back to it over the 2-day face-to-face component of the course. You will find the assessment form attached to the pre-learning here and also be provided with copies over the weekend. We want you to come to the course with not only some form of knowledge in regards to epidemiology and common presentations of musculoskeletal pain and lower limb pathologies, but also we want this pre-learning to evoke some discussion and further questions that we can talk about over the weekend of the course. In this video, we will look at some of the current data available surrounding the burden of musculoskeletal conditions in Australia today. We'll also look at common lower limb musculoskeletal presentations and the patients we expect to present with these complaints in clinical practice, as shown by the data. Musculoskeletal conditions. According to the Australian Institute of Health and Welfare, musculoskeletal conditions are the 4th largest overall contributor to direct health expenditure in Australia, accounting for approximately 8.7% of total healthcare expenditure after cardiovascular disease, oral health, and mental health disorders. In 2015, 31% of Australians with a disability reported having musculoskeletal conditions. What's also interesting is that of those 31% of Australians that are affected by musculoskeletal conditions, 61% are of working age between 25 and 64. Based on the data from the Australian Institute of Health and Welfare, musculoskeletal conditions were responsible for 12% of the total burden of disease and injury in Australia in 2011, and were ranked as the 4th leading contributor to total burden. In the same year, musculoskeletal conditions accounted for 23% of non-fatal burden. When we analyse these musculoskeletal conditions, we see back pain contributing to 31% of total burden of all musculoskeletal conditions, followed by osteoarthritis, which is approximately 17%, and rheumatoid arthritis, which is 16%. So let's have a look at the common lower limb presentations that we see in clinical practice. Have a brief think to yourself now about the most common musculoskeletal conditions and perhaps the most challenging lower limb pathologies that you see in clinical practice at the moment. How do they typically present? Who typically presents with these injuries or symptoms? What's your typical patient that presents with them? And what are their outcomes like? Do they have a successful recovery? Do they have a fast recovery? Or does it take a long time? For example, if we look at runners as a population group, the literature identifies 28 common running-related musculoskeletal injuries. Of these 28 running-related musculoskeletal injuries, Lopez et al. In 2012 identified the most common as medial tibial stress syndrome, Achilles tendinopathy, and plantar fasciitis. What's interesting is that Lopez and his colleagues found that the most common ultramarathon running related injury was not medial tibial stress syndrome, rather Achilles tendinopathy, followed by patellofemoral syndrome. Now let's have a look at a different population, ballet dancers, and the injuries that they commonly present with. If we look at the lower limb injuries that ballet dancers most commonly present with, we can see a big difference in the population compared to the runners that we saw on the previous slide. In a systematic review and meta-analysis by Smith et al. In 2016, 19 studies were reviewed, reporting over 7,000 injuries in over 2,500 ballet dancers. The most prevalent musculoskeletal disorder here included hamstring strains, accounting for just over half of the population, 51%, ankle tendinopathies, which accounted for 19%, and generalized lower back pain, which accounted for approximately 14%. We again see a difference in the presentation in active children. Fernandez et al.'s paper in 2008 looked at the epidemiology of lower extremity injuries among US high school athletes. 9 sports were reported: boys baseball, football and wrestling, girls softball, volleyball, and boys and girls basketball and soccer. Leading diagnoses were sprains at 50%, strains at 17%, and contusion or bruises at 12%, followed by fractures at 5%. If we look at the location of the injury, the ankle was approximately 40% at the most commonly injured site, knees 25%, and thigh 14% were most frequently injured. Fractures occurred most often in the ankle at approximately 42%, and the lower leg at 29%, and foot at 18%. Finally, if we change the population group once again to rugby union players, as analysed by Yomez et al. In 2018, we can again see a difference in lower extremity presentation, with a much more higher presentation of knee and thigh injuries when compared to, say, sprains and strains when we looked at the high school students before. Whilst we could keep analysing other population groups and see an even wider array of injuries, the point is that the presentation we see is likely dependent upon the population. To me, this raises an interesting question. After ruling out red flags, does the specific pathology always matter, or can we approach these musculoskeletal and other musculoskeletal presentations in a similar way? In this section, we are going to outline some of the common issues that we can face in clinical practice. Please note that this is an introduction to certain issues. I'm sure, as you will recognise, that there are many other issues related to the lower limb and pain that we will discuss further in the 2-day face-to-face component of the course. Imaging. When do you currently refer for imaging in clinical practice? Try and think of the last imaging or imaging request that you either referred for, or when was the last time a patient came into your clinic or gym with his or her scans? What were the scans for? It's interesting to note that today in Australia, we are at a point where we have never referred for imaging as much as we do. Keeping in mind, when you look at this graph, that our population has increased by approximately 5% during the period here. However, musculoskeletal rate of imaging in GP practices have increased by approximately 10%, a 2 times growth. When I read data like this, I can't help but think of the associated costs and necessity of the image in most of these cases. For example, is it going to change the way in which the clinician makes decisions going forward? In some cases, yes, but to the same magnitude as the increasing frequency of the imaging itself? According to the Australian Institute of Health and Welfare, in 2014 to 2015, there were 500,000 hospitalisations with the principal diagnosis of musculoskeletal conditions. Of these, 20% were deemed to be direct result of osteoarthritis. We're now going to look at osteoarthritis briefly and the impact it's currently having on Australians. The rate of osteoarthritis in Australia is increasing, with now an expected incidence of 1 in 4 Australians having osteoarthritis. As a result, this increase has led to an increase in imaging, surgeries, and hospitalisations. In the last 10 years, there has been a 39% increase in the rate of total knee replacements for osteoarthritis specifically. Furthermore, 80% of all hip replacements are related to symptomatic osteoarthritis. And by 2020, osteoarthritis is expected to be the 4th leading cause of disability within Australia. So let's have a look at some of the research surrounding the presentation of hip osteoarthritis and diagnostic tools such as imaging. In 2015, a paper by Kim et al. Reviewed 2 studies looking at radiographic evidence of hip osteoarthritis on MRI. Firstly, the Framingham study looked at 946 hips and showed that 15.6% of patients with frequent hip pain showed no radiographic evidence of hip osteoarthritis, and 20.7% of hips with radiographic hip osteoarthritis were frequently painful. Furthermore, the second study, the Osteoarthritis Initiative study, looked at over 4,000 hips, finding that 9.1% of hips in patients with frequent pain showed no radiographic hip osteoarthritis, and 23.8% of hips with radiographic hip osteoarthritis were frequently painful. Interestingly here, it shows that hip pain was not present in many hips with radiographic osteoarthritis, and many hips with pain did not show radiographic hip osteoarthritis. As with hip osteoarthritis, growing evidence is now available surrounding the incidence of knee asymptomatic osteoarthritis. In a systematic review in 2018, 63 studies were reviewed that included over 5,000 asymptomatic knees. What's interesting in this review article is that none of the studies included symptomatic patients. However, many studies showed imaging confirming osteoarthritis. To add to this, as shown by the graph here, we can see a clear correlation between age groups, either over or under the age of 40, and various presentations seen on an MRI. When we look at osteoarthritis in patients below the age of 40, we see a 4 to 14% incidence of osteoarthritis, whereas those over the age of 40 show a significantly higher rate of osteoarthritis within the knee at 43%. This is similar in other knee pathologies on MRI, such as cartilage defects, 11% versus those over the age of 40 at 43%, and meniscal tears, 4 versus 19%. Remember, all studies only included patients who had no symptoms. So we can see the lack of correlation osteoarthritis has with pain compared to findings. So what about other lower limb conditions and imaging? O'Neill et al. In 2017 looked at 320 MRIs of asymptomatic feet. What he found was that 37% of these patients had an ATFL pathology. Of these, 38% had thickening, 35% had a chronic tear, 25% had differences in radiological factors or attenuation, and 2% had an acute tear. Remember, none of these patients had pain. Another interesting imaging study by Lohmann et al. In 2001 looked at 19 non-professional marathon runners and 19 age and sex matched control volunteers. All of these participants had ankle and foot MRIs taken in 3 perpendicular planes within 3 hours of running a full-length marathon. These radiologists then independently analysed the imaging. The aim of this study was to assess the changes within the foot and ankle after exercise, in this case after a full-length marathon. Again, none of these patients had any symptoms. What's interesting is that both the marathon group and the control group both showed an array of pathologies on MRI, as you can see displayed in these 2 tables, or these 2 graphs. These included severe bone marrow edema was in one and slight bone marrow edema in the other 3 marathon runners. Slight bone marrow edema was also found in 3 control subjects. Signal alteration within the soleus muscle, consistent with a grade 1 strain, was found in 1 marathon runner. Small hyperintensities within the Achilles tendon were seen in 26% of the marathon runners and in 63% of the control participants. An increased amount of fluid in the retrocalcaneal bursa was also found in 1 control and in none of the marathon runners. Small amounts of fluid in the retrocalcaneal bursa were seen in 68% of the marathon runners and in 53% of the controls. Again, no one within this study had any symptoms. Even back in 2004, we had evidence of similar results. Bergman et al. Looked at a smaller sample of 21 college runners, none which had pain, and performed MRI of the shin. All runners in the study were participating in an intensive pre-season running program of 8 weeks, during which they ran 50 to 70 miles per week. Exclusion criteria were recent tibial pain or tenderness, or any history of any tibial fractures or stress injury. Again, interestingly, that tibial stress reactions were found within 43% of the 21 asymptomatic college runners. And the biggest take home here is that the presence of these changes were not found to be a predictor for further tibial stress reactions or pain around the shin. We are now also starting to see some fantastic research on Achilles tendinopathy and MRI. We will discuss this in more detail in the course, but what's interesting is that studies are now finding that what Achilles tendons look like on MRI have absolutely no use in predicting the change in symptoms. In other words, if it's suspected that a patient has Achilles tendinopathy or Achilles tendonitis, there should be no reason to scan the Achilles tendon, as it does not change the clinical outcome. We will discuss this in more detail over the course. As health practitioners, it's important to think about the potential negative effects that imaging can have on patients. Nocebo is a word used to describe the potential detrimental effects on health produced by psychological factors, such as negative expectations of treatment or prognosis. And if not educated correctly, it's easy to see how some imaging can lead patients feeling as though they are in a minority with damaged tissues or whatever other negative beliefs that they may develop. Moving away from imaging now, we're now going to briefly look at some of the most frequent surgeries that are performed on the lower limb. Over the past 20 years, we have seen a significant increase in the amount of hip surgeries performed in Australia. This includes an 175% increase in the number of hip replacement surgeries performed in Victoria alone, with the average cost being upward of 20 grand. Knee surgeries have seen similar results over the past few years. When we look at the knee, we see similar trends, with 80% of all knee replacements being total knee replacements, and an increase of approximately 72% of these procedures. The average cost of these procedures are not cheap, at approximately $19,000 per procedure. We now have some fantastic research available looking at the most commonly performed knee surgeries. A systematic review in 2017 by Brignadello and Peterson et al. Looked at knee arthroscopy versus conservative management in patients with degenerative knee disease. This study included 13 randomized controlled trials and 12 observational studies, and showed that there was nil improvement in pain or function with degenerative knee disease, looking at osteoarthritis with or without meniscal damage. The study concluded that over the long term, patients who undergo knee arthroscopy versus those who receive conservative management strategies do not have important benefits in pain or function. We are now seeing strong research with strong recommendation against the use of arthroscopy in nearly all patients with degenerative knee disease, based on linked systematic reviews. Further research is unlikely to alter this recommendation according to these studies. This applies to patients with or without imaging evidence of osteoarthritis, meniscal symptoms, or sudden symptom onset. When we look at the RACGP guidelines, we can see strong evidence against the use of arthroscopy and similar surgeries such as debridement and meniscectomies with cartilage repair within the knee joint. When we look at surgical management on the RACGP guidelines website, we can see surgical management for knee and or hip osteoarthritis, stating, consider joint replacement surgery for severe disease when all conservative options have failed. Perform X-ray to confirm disease severity, referral to an orthopedic surgeon. Do not refer for arthroscopic procedures unless the patient also has a true meniscal locking. We will discuss these guidelines more within the 2-day face-to-face component of the course. We're now going to move on to other pathologies of the knee, anterior cruciate ligament tears. Unfortunately, the incidence of primary ACL reconstructions and secondary ACL reconstructions in Australia have increased significantly over the past 18 years in both males and females. Recent research has shown that 11 to 39% of athletes do not successfully return to sport following ACL reconstructive surgery. What's also interesting is that it's now estimated that athletes are 7 times more likely to sustain an ACL injury in competition rather than in practice. Currently, over 76% of all ACL injuries result in surgery. But is ACL reconstructive surgery essential, or is it even necessary? In a study by Shaw et al. In 2017, the authors looked at trends in paediatric and adolescent ACL injuries within Victoria from 2005 to 2015 and found that there has been a 147% increase in hospitalisation due to ACL injuries in the past 20 years. What's also interesting is that of those hospitalisations, ACL reconstructions and/or arthroscopic surgeries were performed in 98.4% of all cases. A randomised controlled trial by Forbel et al. In 2013 compared young active adults with an acute ACL tear in the midterm, which was a 5-year period, using patient-reported and radiographic outcomes between those treated with rehabilitation plus early ACL reconstruction and those treated with rehabilitation and optional delayed ACL reconstruction. The authors found that there were no significant differences between groups from baseline to 5 years or between 2 to 5 year follow-up. No significant difference between groups from baseline to 5 years in regards to radiographic osteoarthritis of the patellofemoral joint and tibial femoral joint. No significant difference between groups in number of meniscus surgeries performed. Another interesting study looking at ACL reconstructive surgery looked at strength and functional symmetry post-operatively. The study looked at 111 patients with an average age of 27 years old and found that only 5% of all patients received rehabilitation that followed evidence-based guidelines after having an ACL reconstruction. 45% didn't see a clinician after 3 months post-operatively, and 70% didn't perform agility or landing exercise prior to returning to sport, which is quite alarming when we actually look at the evidence in regards to rehabilitation, which we'll look at over the 2-day face-to-face component of the course. We'll look at all of these and more pathologies in detail, but hopefully you've started to question the way in which we're going about some of the pathologies that we see in the lower limb in clinical practice. Some discussion questions going forward which we'll cover over the weekend include the following. Does any non-traumatic musculoskeletal pain presentation only have a pathoanatomical diagnosis that fully explains the patient's pain? I think that's quite obvious, or that answer is quite obvious, but we'll touch on it more over the weekend. Why are structural changes on imaging highly prevalent in pain-free populations? Have musculoskeletal clinicians invented treatments for conditions that may not exist? And we'll talk about other treatment mechanisms that we often use. Have clinicians developed and perpetuated treatment paradigms that do not conform to the current research or evidence? Have clinicians created an expectation that interventions, sometimes and often passive, will provide a cure with minimal self-contribution? Are we providing a cure to the management of a patient's symptoms? Or are we providing a management plan to control the client's problem and limit the impact on the client's quality of life? When symptoms of chronic problems reduces to the level that the client is no longer symptomatic, what strategies do we then put in place so that ongoing self-management is emphasised? And we'll talk about that in detail on the second day of the 2-day course. And finally, what educational strategies do clinicians use to empower patients so that they are not leaving believing that their body is damaged, fragile, and in need of protection? So hopefully these questions we can elaborate more on over the 2-day face-to-face component of the course. Please go forward now and complete the rest of the pre-learning.